So good afternoon to everyone. This is my first visit to Tamil Nadu, and I express my gratitude to all the organizers for having me here. So since morning we've been hearing on various aspects of diabetes, right from weight control, then we talked on lipid control, we talked on management of sleep, and now in the next few minutes I would discuss on management of bone disease, especially the rising osteopenia and osteoporosis in patients of type 2 diabetes. Can I have my slides? Yes, sir. So bone health is one of the neglected aspects of diabetes. The reason is that despite knowing that there is definite skeletal fragility in diabetes, it is a very poorly understood phenomena. And the major problem is that we still do not have ways of proper assessment of skeletal fragility in our patients. So if you see the epidemiology or the availability of DEXA machines, which are the primary requirement for assessment of bone disease, in India, if you see the average, we have one machine for almost 10 million population. So it's almost not available for majority of the population. And more so, there are pitfalls in BMD assessment in patients of diabetes, which I'll come to my talk till the slides.
Sorry for the technical delays, a few seconds.
Yeah, sure. So I'll carry on.
Yeah, sure. We are pleased.
Yeah. So there are differences in type 1 and type 2 diabetes also, because type 1 has a very early disease onset, while type 2, we all know, has a slightly later onset. But then the target for both hyperglycemia is the bones. And that is where we need to understand how we assess skeletal fragility in patients of diabetes and what can be done to prevent them. At the same time, we also need to understand the various factors other than hyperglycemia which affect the skeletal fragility in patients of type 2 diabetes. So, if I could have my slides.
Yes, sir. We are there. We are almost there, sir.
Okay. So I've already given an introduction, and I said it is increasingly recognized but poorly understood. So the outline of my presentation would be, I discuss on the prevalence and outcomes of skeletal fragility. We'll see how is it different from non-diabetics, whether the skeletal fragility is specific for type 1 or type 2, and if yes, then why. We'll also discuss on the effects of anti-diabetic medications on skeletal health, then how to assess and how to manage. So if you see the pathophysiology of skeletal fragility or any fracture in our patients, we either have to have a decreased bone mineral density or a decreased bone quality, and the third contributing factor would be a frequent fall. So if you have any of these factors, probably you could have a patient of diabetes who lands up in fracture. And the fracture risk in diabetes, we have different epidemiological studies which have shown that compared to non-diabetics, that is 32% increased risk of any fracture, and this risk is highest in type 1 versus type 2. In type 2, we have again higher risk for all sites in men compared to women, and we have very few data from Indian studies which shows that almost 30 to 40% of patients of type 2 diabetes have osteoporosis in their life. This is probably one of the longest data where we could compare the fracture risk between various population. It was a population-based data of more than 65 lakh patients with a mean follow-up of 7 years. And what they found that the risk fracture at all sites for diabetes versus non-diabetes, it is 1.32. And this high risk of fracture at all sites in type 1 versus type 2 with highest for hip. Now, when we say highest for hip, you have to take this with a pinch of salt, because many a times the vertebral fractures go unnoticed compared to the hip fractures. And that is why there is more reporting of hip fractures. So it's not like that hip fractures are more common. Interestingly, in type 2 diabetes patient, it has also been found that long-term type 2 diabetes increases the risk of fracture, but for a newly type 2 diagnosed patient, there is a decrease in the fracture risk, probably because of obesity. So there is an opposing effect of overweight or obesity versus long-term diabetes complications, which contribute to the bimodal presentation of fracture risk in patients of type 2 diabetes. So if you see the evaluation of risk factors for fractures in diabetes, it is type 1, they are continuously at risk for fractures. Then type 2 diabetes patients, more than 5 years, poor glycemic control, presence of microvascular complications, and if you have a patient on certain drugs like insulin, sulfonylureas, and thiazolidinediones, they are at a higher fracture risk. And what are the outcomes of these fractures? You can have increased mortality. We have seen a large number of patients, once they develop a hip fracture, they never get up and they land up with complications. At the same time, we have a poor prognosis after a fracture in diabetes because of delayed wound healing, more frequent infections, longer hospital stays, higher post-operative cardiovascular events, and greater rates of readmissions. And that is why we are concerned about preventing fractures in our patients. So coming back to understanding the bone strength now, bone strength has two components. One is the mineral content of the bone, and the other is a bone quality. So we talk in terms of quantity as well as quality. When we talk about quantity, we measure it with the bone mineral density, and that is what a DEXA machine gives. But just remember that only 70% of the variability in bone strength is determined by BMD, which clearly makes you understand that not everything can be calculated with the help of BMD, and that is where we underestimate the risk of fractures in type 2 diabetes patients, because there the problem is not bone mineral density, but it is the bone quality. So we need to address both bone quality as well as bone mineral density. Now coming to the pathophysiology, we all know BMD becomes lower in type 1 than in type 2 because type 1 patients are lean and thin. But if you see the fracture risk, both type 1 and type 2 have increased fracture risk, probably because of both bone poor quality, bone mineral content, and microarchitecture. Diabetes patients are prone to frequent falls, contributed by mainly the peripheral neuropathy, and of course then the medications. But if you see this cartoon on the right-hand side, you can see that when you have diabetes at a young age, especially for type 1, they have a difficulty in achieving the peak bone mass. And the concern now is that we are having more and more younger patients with type 2 diabetes, and there we have a still more concern that probably when we have these patients at the age of 40, 45, they would be at risk of severe osteoporotic fractures. So hyperglycemia leads to advanced glycation products, and that leads to decrease in the collagen content. There is a cross-linking of collagen which is faulty. At the same time, you have hyperglycemia which increases sclerostin, and thereby it reduces bone mineralization, and there is an increased osteoclastic activity which ultimately leads to increased risk of osteoporosis. And this is in more detail and a more molecular pathway who would be interested. So on one hand, you have hyperglycemia, which directly affects increase in adipocytes, which increased adipose tissue deposition within the bones, also leads to osmotic diuresis, causing electrolyte imbalance, especially the calcium and magnesium, and then there is a loss of incretin effect. At the same time, there is increased adiposity leading to leptin resistance and brown fat leading to increased sclerostin, and then you have the inflammatory pathway which leads to increased cytokines and increased bone resorption. So as I was saying, that DEXA recommendations we have for type 1 diabetes, and for type 1 diabetes it starts from late adolescence or for any patients with poor glycemic control. But as I said, DEXA does not estimate the bone quality, and that is where 30% of the cases are missed. And this bone quality, the biggest tool that we have presently is the trabecular bone analysis or the score. Apart from that, you can do a hip structural analysis, you can do a high resolution peripherally quantitative CT, or you can do a bone histomorphometry. But these are more invasive. What is available readily in higher centers is a trabecular bone score. So trabecular bone score is nothing, just it is done using a special software which is based on the pixel gray variability of spine DEXA images. So if you see these images, you can see that there is a uniformity in the porosity in the first image compared to the second image, and the machine calculates this porosity and the uniformity